to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hi, I'm Paul Sachs. I'm Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. And welcome to Clinical Clips from the 2024 AIDS Conference. This is day 1 of 4. Now, the first study I want to cover is looking at HIV RNA or HIV viral load as a screening test for people on cabotegravir PrEP. Now, this was a study done in the context of the open-label extension of HPTN 083, which is, of course, the pivotal study that showed that cabotegravir was very effective, superior to TDF-FTC in prevention of HIV among mostly MSM, as well as trans women. Now, in that study, they showed retrospectively that if you used HIV RNA, you could actually diagnose people who acquired HIV more rapidly than if you just use the usual screening tests, which either are rapid tests or an antigen antibody test. So they then tested this as a testing strategy in the open label extension, and they had over 2,600 participants, and they had both at entry, they tested them with HIV RNA, and then they also tested them each subsequent visit. And this generated a staggering number of tests, 26,000 plus tests of HIV RNA. And in that group, 27 were positive with no other test positive. That means just an isolated HIV RNA. And they looked at that group of 27 tests, and they found that 22 actually were adjudicated as false positives and 5 as true positives. So this led, if you do the math, to an overall predictive positive value of 18.5% and only 9.1% if someone had been adherent to taking their cabotegravir or even had received a dose within the previous 6 months. So the bottom line here is that this is not a very good test in terms of predicting HIV in people on cabotegravir PrEP. So I contacted the lead author of the study, Dr. Rafi Landovitz, who I know well, and he said the bottom line is if you get an isolated positive HIV RNA in someone on cabotegravir PrEP, just repeat it because most of them, if false positives, are going to be negative. The other thing that I can sort of contextualize is that now that this is in the guidelines, I think it's time to seriously reconsider that recommendation, especially for people who are adherent to cabotegravir PrEP, because it's most likely just going to cause confusion. So where would I use HIV RNA in people starting or on PrEP? I would use it at the beginning, especially if you have any concerns about risk exposures. I would also consider using it for people who had not taken their cabotegravir PrEP in the previous 6 months. So that's an important study that has very, I think, critical clinical implications for those of us following people on cabotegravir PrEP. Since I'm on the topic of PrEP, let me stay with HPTN 083 and discuss just what the global experience was with the open label extension. And I'm really just going to focus on one aspect of it, which is that participants were given the choice of whether to go on cabotegravir or TDF-FTC at the end of the study. And remarkably, 96% of participants in the open label extension chose cabotegravir over oral TDF-FTC. So why am I highlighting this result? Well, as I mentioned already, this has been shown to be superior to oral PrEP, and 96% of people offered this in the clinical trial wanted to continue it. And yet when you look at the rollout of cabotegravir PrEP in the United States, at least, it's actually way, way lower than you'd expect from these results. In fact, somebody told me that it's actually in the single digits of total people on PrEP. And this shows that the implementation aspects of pre-exposure prophylaxis are in some ways as, if not more important, than patient preference and effectiveness. So I'm going to stay with long-acting injectables and start talking about now treatment rather than prevention. And of course, the long-acting injectable that's most widely used for treatment is cabotegravir or rilpivirine. I'm going to highlight the Beyond study, which I believe is a nicely done prospective cohort study of people starting cabrolpivirine in clinical practice. And they measured in one poster, they measured the effectiveness, and the other poster, the patient-reported outcomes. And what they found is over a 12-month period that the effectiveness was very similar to the clinical trials. Now, the key thing to focus on in anyone going on cabrolpivirine is that even though it's, quote, non-inferior in the comparative clinical trials, the virologic failure rate with resistance is somewhat higher. So in the clinical trials, about 1%, in this prospective cohort study, about 2%. And conversations with my colleagues around the country and around the world find that it is around 1 to 2%, even for people adherent to therapy. Now, the patient-reported outcomes are very, very positive, and that's actually, in some ways, a self-fulfilling prophecy, but in other ways, very reassuring. So what this tells us is that for people who want to go on long-acting injectable therapy, who actually really want this, say they really want it, if they are then put on this treatment, they really, really like it. Practically all the measures of subjective experiences with treatment are better than when they were on oral ART. Okay, the last study I want to highlight today is on a complication of HIV, and that is anal cancer. Now, we know from the ANCHOR trial that treatment of high-grade squamous intraepithelial lesions, or HSIL, is associated with a reduced incidence of anal cancer. And the results of that study led to a change in guidelines. And you might have noticed that the most recent opportunistic infection guidelines now actually refer to the sort of anal neoplasia guidelines that we should be screening for this condition. And they list 5 screening strategies. One is just to do cytology. The other is to do cytology with some combination with a high-risk HPV testing. And the other is just to do HPV testing. So there are 5 different potential strategies you can use. And what this group from Mount Sinai did is that they have a very established program for anal cancer screening. And they looked at over 1,600 people with HIV over a good long period, a 7-year period, and sort of calculated using the biopsy-proven HSIL as a endpoint. They calculated the sensitivity, specificity, positive predictive value, negative predictive value, and the number of HRA referrals they got based on these different strategies. And the reason why that's important is because even at a place like Sinai, which has a very established HRA program, this is a limited resource. There aren't enough people trained in high-resolution endoscopy for everyone to get referred. And what they found is that while HPV testing, high-risk HPV testing, was the most sensitive approach, it actually had a very low positive predictive value with only 49%. So that means more than half the people referred for high-resolution endoscopy would not have HSIL at all. So if you combine that, though, with cytology in some fashion, then you end up improving the test performance and don't sacrifice much in the way of sensitivity. And then he concluded that this was the most efficient way to move forward. And I think most people who have access to HRA are using a combination of high-risk HPV testing plus cytology to make the adjudication. So thanks for joining us for day 1. Please refer to the landing page for the slides from today's presentations and to claim your continuing medical education credit. And please be sure to come back tomorrow for our second clinical clip from the 2024 AIDS conference here in Munich, Germany. Thanks for listening.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.